start. Here's the first MCQ. You are an intern posted in the Department of Pedia. You are asked to go to the delivery room and do your Abgas score at 1 and 5 minutes of birth. While evaluating, you notice the following deformity in the baby. Notice it. Primarily caused by. Primarily caused by. 4 options. 30 seconds. And there you go. All the best. Answer only in the poll. Avoid answering in the comment box. Very good. You can see that there is a defect. There is a defect, and hence you can easily answer over here. Good. I guess most of you have answered. The defect is lying over here. The defect is lying over here. The lower lip. You should be knowing that how does it during embryology, how is it formed? So the lower lip and the mandible, they are formed by the mandibular arch. They are formed by the mandibular arch. Mandibular arch gives rise to the mandibular process. Both sides mandibular process come and they fuse. If they don't fuse, you get this deformity, cleft lower lip. That is what? That is your cleft lower lip. That is your cleft lower lip. Hence the answer is option number D. That is your answer. Non-fusion of the mandibular process. Okay. You can look at this slide. Here you can see the mandibular prominences. They are both coming and they fuse over here. And if they don't fuse, you have this cleft lower lip, which is a rare anomaly, not very common. But yes, question may be asked. Here we have shown you an image. Okay, next question now. Question number 2 over here. Following an injury suffered in a soccer match, a 32-year-old lady is examined in a seated position in the orthopedic clinic, holding the right tibia with both hands. The clinician can press the tibia backward under the distal part of her femur, right tibia. The left tibia cannot be displaced. Which structure was most likely damaged in the right knee? Okay, so poll over here. But this question, I will give you 15 seconds. Not very difficult. Not very difficult. I give 15 seconds. There you go. All the best. Press the tibia backward easily. Which ligament? Maybe I give you less time, but it's still 28 and 29 and 40. So that is 30 and 40% going with this. Look over here. That was the femur of the lady. That was the leg of the lady in examined seated position, holding the right tibia. This is the right side. The clinician can press the tibia backward. He can press the tibia backward. That is the right side. It is now moving where it is now moving in the backward direction. But if you look at the left tibia, it was fine. It was not moved backward. So here the test is posterior draw test. The test is posterior draw test, and that is to check the stability, to check the integrity of which ligament? Posterior cruciate ligament. Hence the answer is posterior cruciate ligament. Have a look at it again. If you are looking at a lateral view, this is the femur, that is your tibia. Lateral view, anterior, posterior. The green color is the posterior cruciate ligament. It's a posterior cruciate ligament, that is femur and tibia. The blue color is the anterior cruciate ligament, ACL, and this was your PCL. Imagine the PCL is injured. The PCL, imagine, is what? It is injured over here. It is injured. Let's move it from here. And therefore, you can easily move the tibia posteriorly. Easily move the tibia posterior because this ACL is not going to obstruct. Okay, tibia goes back, posterior draw test to check the integrity of the posterior cruciate ligament. Vice versa, if you want to pull the tibia forward, if you want to pull the tibia towards you, you are checking the integrity of ACL. So anterior draw test is for the ACL, the posterior draw test is for the PCL. Clear? Next question. The news reported that a 58-year-old ambassador received a slashing wound to the upper medial thigh. Where? It was in the news because he was a VIP, upper medial thigh, and died after from exsanguination less than 2 minutes. What was the most likely nature of this injury? Upper medial thigh. Look at these 5 options. Look at these 5 options. What was the cause of the death? Femoral artery cut at the inguinal ligament, nerve and vessels at the apex of femoral triangle, femoral vein was transected, medial circumflex, and knee. So 5 options. I will give you this time 30 seconds, and all the best. 2 minutes he died. Upper medial thigh. Anatomy. Think. 30 seconds. Think. last couple of seconds left. 20, 30, 30, A, B, and C. A, B, and C options going 20, 30, 30. So around 70% going over here only. Why so? Answer was what? Answer is your option number B. Option number B. Let us see how. Let us see how the answer is option number B. We shall have a look at it. Now look at this. This is the thigh. That is the thigh region. Okay. Let us assume the right thigh. This is the right side, right thigh, lateral and medial. Lateral and medial. Okay. That is the patella and the. Okay. Here we have the inguinal ligament. Here we have the inguinal ligament. Fine. This is your sartorius muscle going on, and that is say your adductor longus going on. Clear? I hope you got the point. This we are trying to make a femoral triangle. That is your femoral triangle. Okay. Now here is the mid-inguinal point. The femoral artery is coming. Then it goes where? It goes into the subsartorial canal. Here you have a adductor canal known as the subsartorial canal beneath the sartorius muscle. So you have a subsartorial canal over here. So this femoral artery going from mid-inguinal point, and then it goes medially inside the subsartorial canal. Medial to this, you have a femoral vein that also goes below, then behind, then over here into the subsartorial canal. Now, injury was where? In the upper medial thigh. Where is the femoral triangle? Femoral triangle itself is in the upper medial thigh. It is itself in the upper medial thigh. So these vessels, these two important vessels, which are sort of lifeline for the lower limb, they are entering from here. They are lying in the triangle, in a gap, in a depression. Then they come slightly superficially to enter into the subsartorial canal. So here he got the injury in the upper medial thigh at the apex of the triangle, where you have both the vessels very close to each other, and therefore the patient died over here. So answer is a vessel or vessels injured at the apex of the femoral triangle. Now let's see other options. This is in the upper part of the thigh, that is upper not mid thigh, but it is in the inguinal region actually. He got hit where? In the upper medial thigh. Here we are talking the inguinal region, gone. Femoral vein. A vein injury cannot lead to death in less than 2 minutes. It has to be an arterial injury. The medial circumflex femoral vessel was severe erosion, that is quite high up around the same part, 1 or 2 inches below the inguinal region. Same thing over here. These are 1 to 2 inches below the inguinal region. So these are given off quite superiorly over here. The deep femoral artery or the profunda femoris. Upper medial thigh, that is the area in the apex of femoral triangle. Point clear? B is the answer. Next question. One more question over here from the lower limb. I guess it is question number 3. No, sorry, it is question number 4. 45-year-old male is treated at the hospital after he fell from his bicycle. Radiographic examination reveals fracture of both tibia fibula. On physical examination, the patient has a foot drop, but a normal eversion. Which nerve is most likely injured? Now, I guess 15 seconds is enough for this question. And all the very best. Very good. Last couple of seconds. B, C, E. 30, 33, 33, 33. B, C, and E. Okay, understand. The patient has a foot drop. So anterior leg compartment gone, nerve supply DPN. Fine. Then normal eversion. Eversion is caused by the lateral leg compartment. That is your superficial peroneal nerve. That is fine. It is fine. It is positive. This is negative. Obviously, common fibular nerve cannot be, because common fibular nerve gives rise to superficial and the deep peroneal. So obviously that cannot be injured. So tibial obviously cannot be the answer. This answer is option number E. Am I clear? Saphenous is a cutaneous nerve. Tibial supplies the posterior leg compartment. Okay. No CNC involved, and if still ischemia of the limb, how death can occur? I can get you, Amit. No CNC involvement where? Yeah, hello Harshita, hello everyone. In the previous question there was no CNC. What is CNC? Femoral artery could have been ruptured. No. Femoral artery was ruptured. Femoral artery, that will lead to exsanguination. Exsanguination means rapid blood loss. Femoral artery, if you feel the pulsation, you will realize in 2 minutes how much blood can be there. The death was due to bleeding. It was due to hypovolemic shock. Increased pulse rate, decreased BP, that lead to death. Okay. Moving on to the next one. A genetic coding defect. Now look at this question on the thorax part. A genetic coding defect in an early embryo results in absence of lower part of the vertical portion of the cross of the endocardial cushion in the developing heart. Don't worry, we'll explain it. Which of the following malformations most likely present? Where there is the cross of the endocardial cushion, where in the CVS embryology, when the heart is developed, a defect was where in the lower part of the vertical portion. So this is your vertical portion. Defect was where? Defect was in the lower part. Defect was in the lower part. At the center, what you have? Endocardial cushions. What is the most likely malformation? Okay, we'll do a poll. Don't worry. 4 options. Poll is of 15 seconds. Try to answer. Don't try answers and don't type options in the comment box, because that actually deviates every other strand over here. Very good. Excellent. 80%. Best till now. It was the best till now. So yes, it is the endocardial cushion which is at the crux of between the atria above and the ventricles below. Lower part that will form the VSD, upper part of VSD or interventricular septum is membranous part. So this area gives rise to the membranous part. So actually this is your interventricular septum area. That is your interatrial septum. These are your AV canals. These will form the right and left AV canal. Remember the tricuspid and the mitral wall, both the side, contributed by endocardial cushions. So it's a cross. It's a cross. Embryologically coming from sort of neural crest cells. That is also important. Okay, answer is our option number B. Answer is this. Point clear? Yeah, intermembranous in the upper part. One more, abdomen. We're jumping to the abdomen. I guess it is fine. Following involvement in a car crash, a 20-year-old undergoes a splenectomy due to a lacerated spleen secondary to blunt abdominal trauma. Clear? During the procedure, the surgeon ligates the blood supply of the spleen at the hilum. Improper placement of the ligature may lead to damage to the arterial supply of which of the following structures? So improper ligature. Okay. Poll 4 options, 30 seconds. All the very best. Very good. So we can understand over here. Let me try to make it. That is the spleen. Celiac trunk. That is a splenic artery. Very good. 43% good. That is a splenic artery. Fine. So he has to ligate the splenic artery to remove the spleen. But the splenic artery near the hilum gives off branches to the stomach which go via which ligament? These are your gastrosplenic ligament. And the splenic artery is entering via the linorenal ligament. So these couple of branches over here, which was the question? They are the short gastric artery and the left gastroepiploic artery. I am writing in a short form because we have to do more questions. Short gastric artery supplies what? It supplies the fundus part of the stomach. Hence the answer is what? Answer is option number A. Short gastric artery will supply. So if you improper ligature over here may also ligate these vessels. This one should be the muscular part of the IVS because you mentioned lower part. Okay, we are coming to it. First of all, this question. So Sangadeep has asked us question. Don't worry, Sangadeep. I hope this part is clear. So splenic artery gives off the short gastric artery near the hilum. Improper ligature over here may obstruct this artery. Sangadeep, in the previous question, lower part of what? Lower part of the vertical portion of the cross. So this was the cross. That is the whole vertical portion. Upper vertical portion giving rise to part of interatrial septum. Lower vertical portion giving rise to membranous VSD. The muscular VSD comes from the ventricles. This is the muscular intraventricular septum. The muscular intraventricular septum comes from the ventricular wall. It doesn't come from the endocardial cushion. It is only the small membranous part of the intraventricular septum that comes from the endocardial cushion. Point clear? Doubt clear? Good. Let's move ahead. 1-year-old female is admitted to the hospital with a palpable mass within one of her labia majora. Radiographic examination reveals that a loop of intestine has herniated into the visibly enlarged labia majora. This condition is due to a failure of processus vaginalis to close off. From which of the following tissue layers is the processus derived? 5 options, 15 seconds. All the very best. That's a simple question. Process is derived from where? Hmm. 30-30 going with A and C. Let us see why. Process vaginal. Now, what happens is when the testes or the ovary, both male or female genital, when the gonad, let us say when the gonad starts to come from the retroperitoneal into the intraperitoneal, more anteriorly, it carries a sheath of peritoneum with it. That sheath is known as processus vaginalis, and that is a part of parietal peritoneum. It's a part of parietal peritoneum, and it is due to this reason that when a patient has a hydrocele, he has a gonad like a testis over here, and it has a dual covering of the tunica vaginalis. That is known as tunica vaginalis. It has two layers, a visceral layer and a parietal layer, V and P. And when the fluid starts to enter over here, then we start to call it as a hydrocele. So it is same as the peritoneum. So when the gonad will come, they will descend down towards the inguinal canal. They take a sheath of peritoneum with it. That sheath of peritoneum is known as processus vaginalis. Hence the answer is parietal peritoneum. Now, as few of you are going with the transversalis fascia, the defect in it will give rise to the deep inguinal ring. Remember, that is the question. Okay. The defect in the transversalis fascia will give rise to the deep inguinal ring. It does not form this. And what does it contribute to the whole scrotum layers? The transversalis fascia give rise to the internal spermatic fascia. Please note that also. One more question. Very good. It gives rise to the internal spermatic fascia, not the processus vaginalis. Not the processus vaginalis. That is your answer. Problem clear? Okay. Next question. Very good. This one, rotation of the stomach during development results in movement of the left vagus nerve from its original position. There's a movement through approximately how many degrees of rotation does the nerve move? Which nerve? Left vagus nerve move. And what is its final position? Okay, A, B, C, D, E. All the very best. A and C, equal percentage. Answer is A. Answer is A. Let us see why you are going with C also. So to remove that doubt, answer is A. But why? The rotation was of the stomach. Stomach is a component of foregut or midgut? Foregut or midgut? Quick answer. It's a component of foregut. Midgut rotates 270 degree, not the foregut. Foregut rotates 90 degree. Foregut rotates. So answer has to be between A and B. First of all, this question. Then how does it rotate? How does it rotate? Imagine if I take a TS and suppose it's a CT scan sort of image that you have a esophagus or stomach over here, and that is the anterior side, that is the posterior side, that is the right side, that is the left side. Here you have the left vagus nerve, and here you have, let us say, blue color is the right vagus nerve. Now the stomach or the foregut, it will rotate 90 degree in this direction, 90 degree in this direction, such that this left vagus nerve, the left vagus nerve will rotate and it will come over here, final position. The right vagus nerve will rotate and it will come over here, final position. So therefore, when we read stomach anatomy, we say anterior vagal trunk, yes or no? And we say posterior vagal trunk. I hope you remember that simple and gross anatomy of the stomach. So anterior vagal trunk is mainly comprised, I'm using the word mainly, of the left vagus nerve, and the posterior vagal trunk is mainly comprised of the right vagus nerve. Am I clear? 90 degree rotation. Understand, 90 degree rotation. 270 degrees for the midgut. 270 degrees for the midgut. If they would have asked you jejunum or ileum, something like that, then we could have thought of that thing. Here you have 90 degree rotation. Point clear? Okay. Next one. Another beautiful question. 23-year-old lady is admitted with a severe abdominal pain, nausea and vomiting. History taking shows that the pain is acute and has been constant for 4 days. Okay, acute pain with 4 days. This lady must be really in some pain. 4 days, too much pain. The pain began in the epigastric region, radiated bilaterally around the chest to just below the scapula. Look at the radiation. It began in the epigastric, upper part of the abdomen. It moved around the chest, moved below the scapula, behind. Currently, the pain is localized in the right hypochondrium. So And so this is the whole picture. Let me just draw it like this. Pain normally started from here and then it moved behind. Then it moved behind. Fine. Now the pain is over here. A CT scan revealed calcified stones in the gallbladder called lithiasis, which nerve is carrying the afferent fibers of the referred pain. So remember that referred pain which started from here, it went back below the scapula. Which nerve is carrying that pain? The diagnosis is cholelithiasis. The diagnosis is cholelithiasis, stones in the gallbladder. Greater splenic nerve, dorsal primary rami, phrenic, vagus, or pelvic splenic nerve. Poll, 5 options, 15 seconds. All the best. Good. 30 and 43% A and C. So majority of you are going with the C, but the answer is what? A. Answer is what? A. Greater thoracic splenic nerve, not the phrenic nerve. Let us explain it how. Let us explain it how. Just take one minute over here. Remember, when there is a visceral pain is carried by the sympathetics. Please remember that. It's carried by the sympathetics. Fine. Okay. Now, gallbladder is a component coming from the hepatic bud. Hepatic bud is coming from the foregut endodermal. Remember that there was a diverticulum in the foregut known as hepatic bud. So it is coming from the foregut. Okay. Now we have three parts of gut: a foregut, midgut, and hindgut. Okay. What is their sympathetic supply? Sympathetics is coming from where? In the whole body, the sympathetics comes from T1 to L2. I hope you know that. Sympathetic outflow is from T1 to L2 from the spinal cord. Now, upper part like T1, T2, T3, T4, they are for the head, neck, and thorax region. So from T1 to around T4 or T5, it is dedicated to what? It is dedicated to head, neck, and the thorax region, even including the viscera, the heart, and the lungs, all of that. Below T5 or from T5 to around say T12 it is related to what? It is related to the abdominal viscera. And then they are divided like T5 to T9, it is known as greater splanchnic nerve. It is dedicated to foregut. Okay, T5 to T9, greater splanchnic nerve. Now T10, T11, they are lesser splanchnic nerve dedicated to midgut. And below this you have T12, maybe L1, may not be, that is dedicated to hindgut. So they are known as greater splanchnic nerve, lesser splanchnic nerve, and least splanchnic nerve. So here we were dealing with a foregut viscera, from the foregut hepatic bud, from the hepatic bud gallbladder. So its pain would be carried by this T5, T9. What is that known as? Greater. Was that in the option? That was clear cut in the option. Now look at its root value. What was the root value of greater splanchnic nerve? One more hint. T5 to T9. Where did the pain went? In the lower part of the scapula. If you look at the scapula, if you look at the behind, if you look at the whole scapula, then tell me what is the vertebral level of the inferior angle? What is the vertebral? T7 or T8? Is it falling in T5 to T9? Yes, it is falling. Yes, it is falling in that range of greater splanchnic nerve. So that was another hint. Now, if you are choosing phrenic nerve, fine. You can choose phrenic nerve. What is the root value of phrenic nerve? First of all, C3, C4, C5. Where would the pain go? It will go into the shoulder region, not behind the scapula. The question asked was, which nerve is carrying the afferent fibers of the referred pain? Referred pain. Splanchnic will carry the referred pain. Look over here. Is the point clear to all of you? Is the point clear to all of you? That is very, very important. You need to understand how the patient is presenting the pain. Which nerve is that? Which nerve is that? Okay. Okay. Next one. Answer this. Again, abdomen. Exploratory laparoscopy was performed on a 34-year-old male following a successful emergency appendectomy. Okay. Which of the following anatomical relationships would be seen clearly without dissection when the surgeon exposes the beginning of jejunum? That is a tricky question. Look at the last line only. Forget about appendectomy and the exploratory. Which anatomical relationship would be seen clearly without dissection when the surgeon exposes the beginning of jejunum? Suppose you are not visible. Guys, give me a thumbs up if you can see the question. Can you see the question? Yes, Lokesh, they are seeing, so just refresh your system. Okay. So question is, when you're opening the abdomen, you're doing an exploratory laparotomy, open the abdomen, you took that whole jejunum, those tubes, like those, like it looks like a tire tube, no? When you go for the puncture healing in a puncture shop, so that tube is jejunum ileum. You lift it up, you go towards the proximal part of jejunum, keep going, keep going, keep going, keep going. You reach the initial part of jejunum. At that point, without using your scalpel or any instrument, what relationship would you see? That is the question. Okay. Second portion of duodenum is related anteriorly, supramesenteric artery and vein. Portal vein crosses this. Second part duodenum is crossed anteriorly by transverse mesocolon. And A, B, C, D. 5 options. I'll give you 30 seconds for this question. Think and answer. Very good. Last 10 seconds. Very good. 40% of you correctly answering it, but others spreading all around. Let us share the leaderboard also. Very good. You have done 10 questions. Very good. Jayansh, Rachna, Puneet, and others also. So what do we see normally is the option number D. That is what you will see normally. Once you reach the initial part of the jejunum. Let us see other options. The second portion, duodenum, is related anteriorly to the hilum. That statement is right, but you won't see it because it is behind the duodenum. Duodenum itself is a retroperitoneal organ. Supramesenteric artery and vein passes posterior. They don't pass posterior, they pass anterior to the third part. So that statement is wrong. Portal vein crosses anterior to, that statement is wrong. It is found posterior to the neck of pancreas. So B and C statement are wrong. Third part of duodenum is related anterior to the hilum of the left kidney. Not particularly we can say hilum of left kidney. Some portion may come, but normally doesn't come. It's the jejunum part which comes. That statement also not wrong, not right. So A and D are right over here. You won't see A, you can see D. D is second part duodenum is crossed anteriorly by the transverse mesocolon. So what normally occurs is, you have this stomach over here, and you have this jejunum over here, sorry, duodenum, and then you have the jejunum. Jejunum, let us make this blue color. That is the jejunum. Now we have reached over here, proximal part of jejunum. This is the attachment of the transverse mesocolon. Okay, and how will you reach the jejunum? Understand. From the stomach, this was the greater omentum. Am I correct? From the stomach, this was the greater omentum. So once you open the abdomen, you see the greater omentum. Then what you do is you lift the greater omentum. Once you lift this, and that greater omentum comes over here, you see transverse colon inside it. So let me mark it like this. This is imagine the greater omentum which you have lifted. And after lifting of it, what do you see? You see a transverse colon over here. And then you see what? You see transverse mesocolon over here. Only then you will see the small intestine inside the abdomen. Once you lift the greater omentum, then you will start to see the small intestine. Then you took this jejunum and you went proximally, and then you reached over here. Now what will you see? You will see this attachment of the transverse mesocolon on the second part duodenum, including the pancreas over here. There would be a pancreas also running. It is going in front of that also. This is what you see. Point clear? Is this point clear? So what do you see when you reach the jejunum was the question. You have to think about it. So topic is relation to duodenum. Yes, topic is yes.